All right, this chapter we'll be looking at facial and neck injuries. So, some medicine applies fundamental knowledge to provide basic and selective advanced emergency care and transportation based on assessment findings from an acutely ill patient. So, some recognition and management of nose trauma applies fundamental knowledge to provide basic and selected advanced emergency care and transportation based on assessment findings of acutely injured. So, life threats of spinal trauma in the head, facial, neck, and spine area. Penetrating neck trauma, laryngotracheal injury, spine trauma, and facial fractures. Some skull fractures, foreign bodies in the eye, and dental trauma. Face and neck was subject to traumatic forces, soft tissue injuries, and fractures to bone are common and sometimes life-threatening. Penetrating trauma to the neck may cause severe bleeding. Open injuries may allow for air embolism to enter the circulatory system. It may stop or slow blood flow to the brain also. So as an advanced EMT, your objectives when treating a patient with face and neck injury should include prevention of further injury, particularly to the cervical spinal area itself, managing acute airway problems, and control blood. Bones and landmarks. Head is divided into the cranium and the face. Facial skeleton is composed of 6 major bones: the nasal bone, 2 maxilla, 2 xylem, mandible. The orbit of the eye is composed of the lower edge of the frontal bone of the skull and xylem. Principal structures of the anterior region of the neck include the thyroid, cricoid cartilage, the trachea itself, and numerous muscles and nerves. Cricoid cartilage is a foreign ridge of cartilage found below the thyroid cartilage. The cricothyroid membrane joins the thyroid cartilage and cricoid cartilage. Lateral of these vessels and nerves lie in the sternocleidomastoid muscle. So you see the thyroid cartilage, you see the cricoid cartilage, the cricoid thyroid membrane is there in the middle too, and then it goes down into the trachea. The eye is a globe shape, approximately 1 inch in diameter. It's located within a bony socket in the skull called the orbit. It's held in place by loose connective tissue and several muscles. Oculomotor nerves innervates the muscle and carries parasympathetic nerve fibers. The optic nerve provides the sense of vision. The orbit itself forms the base of the floor of the cranial cavity. Directly above it is the frontal lobes of the brain. The eyeball, which is the globe, keeps the global shape of the as a result of pressure from fluid contained within the 2 chambers. Anterior chamber is filled with aqueous fluid. The posterior chamber is contained with vitreous humor. The sclera extends over the surface of the globe. The inner surface of the eyelids are exposed to the surface of the eye itself, are covered by conjunctiva. It's kept moist by fluid produced by the lacrimal glands. The opening in the center of the iris is called the pupil. Some people are born with pupils that are not equal. The ear is a complex organ associated with the hearing and balance. It's divided into 3 parts. The external ear is composed of the pinna and the external auditory canal. The middle ear contains 3 bones: the malleus, incus, and stapes. The inner ear is composed of the bony chambers filled with fluid. So, soft tissue injuries and neck injuries are very common areas of extremely vascular. Swelling may be more severe. Bleeding from penetrating traumas may be heavy. Blunt trauma injuries may cause a hematoma. So their presence suggests that the potential for more severe injuries. And that picture to the right, that's pretty significant there. So always maintain a high index of suspension when treating a patient for closed soft tissue injuries. The risk of airway compromise is very great and blood is very large. So, and it will cause gastric irritation if it's swallowed. Facial fractures occur when facial bones absorb the energy of a strong impact. The magnitude of force required to fracture the maxilla will produce closed head and cervical spine injuries. Protect the cervical spine and monitor neurologic signs, specifically the level of consciousness. Signs and symptoms include deep facial lacerations, pain over a bone, ecchymosis, swelling, pain of palpation, crepitus, misalignment of teeth, facial deformity or asymmetry, instability of facial bones, impaired ocular movement, and visual disturbance. Nasal fractures is the most common facial fracture. It's characterized by swelling and or crepitus. Deformity in the nose usually appears as lateral displacement of the nasal bone, often complicated by the presence of an anterior posterior nosebleed epistaxis. The mandibular fracture results from massive blunt force trauma to lower third of the face. The fracture site is most commonly located at the angle of the jaw. Suspecting patients with a history of blunt force trauma to the lower third of the face presenting with dental malocclusion, numbness of the chin, and inability to open the mouth. Point tenderness and pain can identify injuries that patients might not have otherwise reported. So maxillary fractures occur with mechanisms that produce massive blunt force trauma. A Fort fracture 1 is horizontal fracture of the maxilla. So it separates the hard plate and the lower maxilla from the remainder of the skull. A Fort 2 is fracture involving the nasal bone and the inferior maxilla. Separates the nasal bone and the lower maxilla from the facial skull and remainder of the cranial bones. A Fort 3 fracture is fracture of the midfacial bones. It separates the entire midface from the cranium. So, orbital fracture. An example can be a blowout fracture. Sometimes in symptoms, double vision, loss of sensation above the eyebrow, over the cheek. Patient may have reduced sensation to areas innervated by the infraorbital nerve. Massive nasal drainage, impaired vision, and paralysis of upper gaze may occur. Zygomatic fractures commonly result in the blunt trauma in MVCs and assaults. Signs and symptoms include side of the patient's face that is fractured appears flattened, loss of sensation over the cheek, nose, and upper lip, and paralysis with a upward gaze. Associated injuries and conditions include orbital fractures, ocular injury, and epistaxis. Dental fractures or dental injuries, fracturing of the volus teeth are very common. May be associated with mechanisms that can cause severe maxillofacial trauma and may occur in isolation. Always assess these patients' mouth falling and facial injury. Teeth fragments can become an airway obstruction. Leave well-feeding dentures in place. So, you're seeing size up, observe for hazards and threats to the safety. Take BSI, determine the number of patients, look for your mechanism of injury, and consider how mechanism of injury produced with injuries is expected. Identify and manage life threats. Combative and aggressive behavior can be a sign of a closed head injury. Check for responsiveness, ensure a clear and patent airway, and suction any blood, fluid, or vomit. Remove the teeth fragments, consider inserting a properly sized airway adjunct if the patient is unresponsive. So nasal MPA should not be used in any patient with suspected nasal fractures. Assess for adequacy of breathing, call for paramedic backup, cause instructive intubation may be the method of choice for airway. Your history taken, get your medical history, be alert for injury-specific signs and symptoms, and be aware of pertinent negatives. So, attempt to gather from friends and family, or family if the patient is unresponsive, consider with your simple history. From a response patient, you will only be able to notice signs of injury. And your secondary assessment, if significant trauma has likely affected multiple systems, perform full body scan, look for DCAT BTLS. So do not delay transport to complete a thorough physical examination and ensure controlled bleeding is maintained and no injury location. Inspect open wounds for foreign matter and stabilize impaled objects. And you may not always have time to conduct on secondariness. So, in a responsive patient who has an isolated injury with limited mechanism of injury, focus physical examination on the isolated injury, patient's complaint, and body region affected. So, do the facial bones seem to be in alignment, and does the nasal bone seem to be deviated from midline? Do the facial bones seem to be in alignment? Does the nasal bone seem to be deviated from midline? And note variations in nasal facial examination, such as is there any facial drooping? Does one eye appear to be lower than the other? So if so, this could be an indication of an oral fracture. Repeat your primary assessment and your reassessment. Reassess your vital signs to complaint. Check your ABCs, check your interventions, and provide complete spinal mobilization. Each patient with suspected spinal injuries. High flow 2, control visible bleeding, treat for shock, and transport to facility appropriate care. Two large bore IVs, and don't waste any on time. And consider your 20 mL per kilogram of isotonic crystalloid solution to maintain radio pulse. So, communication and documentation includes a description of the mechanism of injury and position you found the patient in. Document the method used to remove the patient from the vehicle. Estimate and report the amount of blood loss that has occurred and how rapidly and how much time has passed since the bleeding started. Always call and inform the hospital early on your trauma alert. So, soft tissue injuries, you want to focus on protecting the airway. Do your ABCDE, BSI, open and clear the airway in the absence of life-threatening bleeding. Secure and maintain a patent airway and take appropriate precautions for suspected cervical spine injury. Cover exposed parts with a moist, sterile dressing. Treat facial lacerations and avulsions, has any other soft tissue injury, and check for bleeding inside the mouth. Wrap portions of a bull's skin that have become separated in a sterile dressing, moistened with a saline, and place them in a plastic bag in a cool temperature. Never place tissue directly on ice. And deliver the bag labeled with the patient's name to the ED along with the patient. The skin is attached in a loose flap. Place it in a position that is closed to normal as possible. Injuries to the eyes, proper emergency management will minimize pain and help prevent permanent loss of vision. In a normal, uninjured eye, the entire circle of the iris is visible. Pupils are round, usually equal in size, and react equally when exposed to light. Both eyes move together in the same direction when following your moving finger. After injury, pupil reaction or shape and eye movement are often disturbed. Abnormal pupil reactions sometimes are a sign of brain injury rather than an eye injury. So look for specific abnormalities or conditions that may suggest the nature of the injury. Following the object, the conjunctiva becomes inflamed and red conjunctivitis, and the eye begins to produce tears in an attempt to flush out the object. Irritation of the cornea or conjunctiva causes intense pain and is aggravated by bright light, so the patient may have difficulty keeping the eyelids open. So if you have a foreign object in one eye, just advise the patient, and I usually just cover both eyes, and try to stabilize your foreign body or your foreign object, and then cover it with the other eye that way. And just keep your in mind that these patients are basically blind at this point, so you have to coach them along. Foreign bodies may be impaled into the eye, must be removed by a physician. Stabilize the object in place and prepare patient for transport. The greater the length of the foreign object sticking out, the more important stabilization becomes. bandage the object in place to support it and cover the eye with a more sterile dressing. Surround the object with a donut-shaped, not donut glazed. Don't go buy a donut. Donut-shaped collar and made from a roll of gauze or a small gauze pad, and basically you can do that by cutting it partially in half. Burns of the eye stop the burn and prevent further damage. Chemical burns usually caused by acid or alkaline solutions. So flush the eye with clean water or sterile saline irrigation for about 5 minutes. So ideally, you will use a boil or irrigation syringe, a nasal cannula, or some other device that will allow you to control the flow. If not available, pour water into the eye by holding the patient's head under a gently running faucet. If only one eye is affected, take care to avoid getting contaminated water into the unaffected eye. Irrigate the eye for at least 5 minutes. Flush the inner corner of the affected eye towards the outside corner. If the burn was caused by an alkaline or a strong acid, irrigate the eye continuously for 20 minutes. After completing the irrigation, apply clean, dry dressing to cover the eye and transport. If irrigation can be carried out in an ambulance, it should be done during transport. So these are chemical burns to the eye. Thermal burns, burning of the eyelid, requires very specialized care. Provide transport to these patients without further examination, and cover both eyes with a sterile dressing and moisten with sterile saline, and you may apply eye shields over the dressing. Light burns, infrared, eclipse light, and laser burns all can cause significant damage. So, retinal injuries caused by exposure to extremely bright light are generally not painful but may result in permanent damage. Superficial burns of the eye can result from ultraviolet rays from an arc welding unit, light from prolonged exposure to a sun lamp, or reflected light from a bright snow-covered area. The burn is not painful but may become so 3 to 5 hours later. Severe conjunctivitis usually develops with redness, swelling, and excessive tear production. Cover each eye with a sterile dressing, moist pad, and an eye shield. Have the patient lie down during transport and protect him or her from further exposure to bright light. Lacerations require very careful repair to restore appearance and function. If there is a laceration of the globe itself, apply no pressure to the eye. Treatment guidelines never exert pressure on or manipulate the injured eye in any way. If part of the eyeball is exposed, gently apply a moist sterile dressing to prevent drying, and cover the injured eye with a protective metal eye shield, cup, or sterile dressing. Apply soft tissue dressings to both eyes and provide prompt transport. The eye may be displaced from its socket. Do not attempt to manipulate or to reposition it. Cover the eye and stabilize it with a more sterile dressing. Cover both eyes to prevent further injury, and have the patient lie supine to prevent loss of fluid from the eye. Blunt trauma injuries range from the ordinary black eye to a severely damaged globe. Hypnea is bleeding into the anterior chamber of the eye and obscures all part of the iris. It's common in blunt trauma. Cover the eye to protect it from further injury and transport. Hypnea or rupture of the globe may signal the presence of a spinal injury. Elevate the head and the backboard to approximately a 40-degree angle to decrease intraocular pressure. Discourage the patient from performing activities that may increase IOP. Orbit fracture, also known as a blown-out fracture, typically a fracture from the bones that form the eye floor and support the globe. Place the patient on a stretcher and transport promptly to the ED. Protect the eye with a metal shield and cover the other eye to minimize eye movement. Retinal detachment, separation of the inner layers of the retina from the underlying choroid. Often seen in sports, especially boxing. It is painless but produces flashing lights, specks, or floaters in the field of vision and a cloud of shade over the patient's view. Eye injuries following a head injury, possibly Possibility of a head injury, one pupil larger than the other. Eyes do not move together or they point in different directions. Eyes fail to follow movement of your fingers as instructed, and bleeding of the conjunctiva, which obscures the sclera. Protrusion or bulging of one eye. So for unresponsive patients, keep the eyelids closed, cover the lids with a moist gauze, and hold them closed with clear tape. In blast injury, management depends on the severity of the injury. If a foreign body is embedded within the globe, do not attempt to remove it. Use a clean cup or similar item to protect the area. If only one eye is injured, follow your local protocol. If the patient has severe swelling or a hematoma to the eyelid, do not attempt to force the eyelid open to examine the eye. Right, contact lenses and artificial eyes. Never attempt to remove a lens from an eye that may have been injured. The only time the contact lens should be removed immediately in the field is in the case of a chemical burn of the eye. To remove a hard contact lens, use a small suction cup, moisten it with the end of saline. To remove a soft one, place 1 or 2 drops of saline in the ear and gently pinch the lens together between your little thumbs and index finger. And so it then just lifts it off the surface of the eye. Place the contact lens in a container filled with sterile saline solution to prevent damage. Inform the ED if a patient is wearing contact lenses. Suspect an eye is artificial when it does not respond to light, does not move in concert with the opposite eye, or appears different from the opposite eye. Injuries to the nose. Nosebleeds or epistaxis are common. One of the most common causes is digital trauma itself. Characterized by anterior and posterior based on the bleeding area. Anterior nosebleeds usually originate from the area of the septum and bleed fairly slowly. Posterior nosebleeds are usually more severe and often cause blood to drain into the patient's throat. Blunt injuries to the nose caused by a fist or dashboard may be associated with fractures and soft tissue injuries of the face, head injuries, and or injuries to the cervical spine. Assess all structures of the nose for injury. Patients with severe injury may have injury to the cervical spine also. CSF fluid may escape down through the nose or ears following a fracture at the base of the skull. This figure shows 2 chambers of the nose divided by the septum. Each chamber is composed of a layer of bone called turbulence, and above the nose are the frontal sinuses, and on either side the orbit of the eye. Epistaxis following the facial trauma is most effectively controlled by applying direct pressure to the nerves. Control bleeding from abrasions and lacerations by applying a sterile dressing. Assess patients for the signs of hemorrhagic shock and administer crystalloid fluid boluses intravenously. Injuries to the ear. Isolated ear injuries can result in sensory impairment and permanent disfigurement. So they do not usually bleed very much. If local pressure does not control bleeding, apply a roller dressing. First, place a soft padded dressing between the back of the ear and the scalp. Bandaging the ear against the scalp can be extremely painful. If blood or cerebral spinal fluid drainage is noted, then apply a loose dressing over the ear. If the pinga is partially avulsed, carefully realign the ear into position. Gently bandage it with sufficient padding that has been slightly moistened with normal saline. Attempt to retrieve avulsed part for reimplantation. All foreign bodies should be removed by a physician in the ED. Do not try to manipulate the foreign body. Signs and symptoms of perforated tympanic membrane include loss of hearing and blood drainage from the ear. Facial fractures. If the patient sustained a direct blow to the mouth or nose, then maintain a high index of suspicion for a facial fracture. Other clues include bleeding in the mouth, inability to swallow or talk, absence or loose teeth, loose and or movable bone fracture. Facial fractures alone are not accurate acute emergencies unless there is serious bleeding. Indications of significant blunt force trauma. Serious bleeding can be life-threatening. Blood clots may become lodged in the upper airway and cause obstruction. Plastic surgeons can repair damage to the face and mouth if injuries are treated within 7 to 10 days. Remover and save loose teeth, and or bone fragments from the mouth because it often possibly can implant them. Oral and dental injuries, blunt mechanisms typically result from MVCs or direct blows to the mouth or chin. Penetrating mechanisms include gunshot wounds, lacerations, and punctures. Primary risk is airway compromise from oropharyngeal bleeding. Suction of the oropharynx is needed and remove fractured teeth fragments. Apply spinal mobilization as dictated by the mechanism of the injury. Apply direct pressure to stop the bleeding. For severe oropharyngeal bleeding in patients with an inadequate ventilation, suction the airway 15 seconds to provide ventilatory assistance for 2 minutes. So leave the impaired object in the face in place and appropriately stabilize them unless they pose a threat to the airway. Pat the inside of the patient's cheek with sterile gauze and apply counter pressure with a dressing and bandage firmly secured over the outside of the wound. When dealing with an avulsed tooth, handle it by its crown and not by the root. Do not allow tooth to dry. Notify the receiving facility about the avulsed tooth. Injuries to the neck. Any injury to the neck is serious and should be considered life-threatening. Blunt injuries, any crushing injury of the upper part of the neck is likely to involve the larynx or trachea. Once the cartilages of the upper airway and larynx are fractured, they do not spread back to the normal position. So this can lead to loss of voice, difficulty swallowing, severe and sometimes fatal airway obstruction, and leakage of air into the soft tissue of the neck. Subcutaneous emphysema is a characteristic crackling sensation produced by the presence of air into the soft tissues of the neck. If you feel this when palpating the neck, maintain the airway as best you can and transport immediately. Complete airway obstruction can develop very rapidly. If the airway is very difficult to manage, consider paramedic support. Some patients may require surgical airway at the hospital. An incident involving an injury to the throat may also have caused a cervical spinal injury, so spinal stabilization may be needed. Penetrating trauma, the primary threats are massive hemorrhage and airway compromise caused by swelling. Penetrating injury can cause profuse bleeding from laceration of carotid arteries and jugular veins. Injuries to the carotid and jugular veins in the neck can cause the body to bleed out. Possibility of a fatal air embolism, a large amount of air entrained into the right atrium and right ventricle of the heart can lead to cardiac arrest. Immediately seal open air neck wounds with an occlusive dressing. Avoid constricting the vessels and structures of the neck. Be alert for swelling and expanding hematoma. Apply dressings above and below the penetrating wound. Do not remove any impaired objects. Maintain cervical spinal mobilization and provide prompt transport. So while you're out to the hospital, ensure your airway remains open, high flow tube, and obtain vascular access. Laryngeal injuries, when the larynx becomes crushed against the cervical spine, soft tissue injury, fractures, and or separation of the fascia can result. Open injury to the larynx can occur as a result of stabbing or other penetrating trauma. Penetrating or impaled objects other than the larynx should not be removed unless they interfere with cardiopulmonary resuscitation. So stabilize all impaled objects if they are not obstructing the airway. Maintain a high index of suspicion and perform a careful assessment of any patient with blunt trauma to the anterior part of the neck. Signs and symptoms of laryngeal injuries are respiratory distress, hoarseness, pain, dysphagia, hematitis, cyanosis, pale skin, sputum in the wound, subcutaneous emphysema, bruising on the neck, structural irregularity, hematoma, and bleeding. Esophageal perforation can result in mediastinitis. To manage the laryngeal injury, provide O2 and ventilation, apply a cervical collar, be alert for the need of frequent suction, and do not delay transport. Always call for paramedics if airway management is needed. Muscular injuries, Most of the non-penetrating injuries are classified as sprains and strains. A sprain is a stretching or tearing of a ligament. The muscle contracts, has the intent to support the neck, maintain a high index of suspension for cervical environment, and provide cervical spine and stabilization. A strain is stretching or tearing of the muscle or tendon. The most common form of the cervical strain is often called whiplash. It is recommended to transport these patients for the ED for radiological studies. Conduct a visual inspection for signs of soft tissue injury. If you suspect musculoskeletal injury to the neck, addressing airway ventilation or oxygenation consideration. So focus on preventing further injury. Check distal pulses and sensory motor function. Always see spine these patients. We don't have X-ray vision, so we don't know if the neck is actually involved or not as far as the spinal area itself. Helmets, face shields, mouth guards, and safety eyewear help to prevent injury. So it's better occupant safety restraints and airbags help prevent contact with the interior of the vehicle. Improvements to headrests reinforce a number, creates and reduce a number of neck strains. That accompanies injuries to the soft tissues, injuries to the brain and or cervical spine. Injuries to the great vessels in the neck can cause significant bleeding and pressure on the upper airway itself.